now we move forward and would like to invite Dr. Manoj Mahajan, Senior Consultant Medical Oncologist from Udaipur. And as a panelist, I would like to invite Dr. Prathamesh Pai sir. Dr. Shiva is there. Kumar sir, can you join Nita madam? And Dr. Bhavesh Poladia, Consultant Medical Oncologist from the Makar.
We are also learning. So, good evening, everyone. So, we'll be, as we are running short of time, we'll quickly go through the case. So, this head and neck cancer session, a 40-year male, case of recurrent relapse carcinoma tongue with metastasis to bones, bilateral adrenals, bilateral lungs, spleen, bilateral kidneys, and bone marrow. So, quite extensive disease. And to start with, at the onset, patient was locally advanced disease post 3 cycles of DCF, underwent surgery, then CTRT in 2022, had recurrence after a year, which was non-salvageable. Then patient received pembrolizumab plus paclitaxel, followed by cetuximab, gemcitabine, triple metronomic therapy, vinorelbine. So the obvious question is, what next? Either in the form of testing, will we do something which will guide us for any
what else treatment?
So patient has received DCF earlier, then pembro paclitaxel, cetuximab gemcitabine, triple metronomic, vinorelbine.
So we do many more things beyond that. In fact, we have published some of those data on bendamustine. We have got some data on mycidaxi. We have used lenvatinib. So ideas. What I'm saying, these are not will have a guideline. But whatever I mentioned, if you go back and check, you will get data of phase 2 where there are 15% patient where the tumor regresses. So is patient stable? And why do I use it? These are off-label use. And off-label, there is a way to use it. Off-label is one of the one of the way you practice, and if you go, there is a ASCO guideline for it. That how do you use off-label treatment? So you see that safety is there or not, what I was suggesting. And when you're using it, when you've exhausted the routine treatment, yes, and I told you, some of them we have used it, and some of them we have published it, and that is in a public domain. If not, capecitabine. If you have gone through this, yes. Only DCF has been used, not sure how many cycles were there.
3 cycles.
3 cycles. So that becomes a bit troublesome, but yes. If you have a 2-3 years gap, go back. If you see capecitabine, again you have a data for around 20% patient responding to head and neck cancer with these treatment. So you'll realize that in clinic you will have patients, not everybody, good number of them in your career who will keep coming to you. They are fairly stable, disease increases, and then you look for, is there some treatment where the data is there to use it?
So we always search for the fallback options. So we had tested this patient for with the NGS testing. So patient had HRAS mutation, and tiprafenib was denied. And patient was not willing for TCR due to time requirement. And then patient was recommended for gamma delta T cell therapy. Baseline markers were more or less normal. These were the markers. And as we have the NCCN recommendations, most of them, again in the similar pattern, we had exhausted with most of the standard current options. And if we look at the overall PFS with the pembrolizumab plus cetuximab, it's hardly around 3 months, 4 months, 15 weeks to 25 weeks. And then other options, which like OMCT or IV chemotherapy, median PFS is around 2 to 3 months, median OS is around 4 to 6 months. And even with the cabazitaxel, there was published data by the TMH and SIR only. So it has non-inferiority with the to be inferior with the docetaxel, both in terms of PF and OS. So we have the published data, but again the median PFS and OS of 2 to 3 to 4 to 6 months respectively. So again, this is cellular therapy workshop. So do we have any data in this domain? So we had certain markers like B7H3 for skull-based chordoma as ERB plus MUC1 targeted CAR T cell in SCC. Then results of ERB CAR T, especially patient who had received 8 lines of chemotherapy. So this patient who has been reported after 8 lines of chemotherapy with standard all the options including surgery, radiotherapy, chemotherapy. This patient, such group of patients, around median PFS was around, overall survival was around 250 days, so more than a year, and few of the patients had data going beyond 400 days. So again, the TCR engineered T cells targeting E7, again this group of patients, all the patients had responded, and survival was around 6 to 10 months, 6 to 9 months after multiple lines of chemotherapy. So that is the one area where we can think about adding the cellular therapy. Again, the overexpression of HER2 in head and neck cancer represents the patients, as nowadays we are using NR2, and after NR2 also we have option of using the CAR T cell in such subset. So for this patient, gamma delta T cells infusion was done on 14th of August. Dose infused were around 174 millions. Patient had first fever spike 104 on day 2 of the infusion. Then patient was managed conservatively. Medications were done. The date of infusion, second infusion for the gamma delta T cells, 28th of August, 160 millions of cells. Patient complained of, patient had ICANS, complaints of confusion while typing and writing the message or email. Then patients' responses were recorded day 0, day 30 and day 60. So we are like day 70 plus, but at day 60, these were the results. And so tumor is responding. We don't know, we are not very sure how long the response will last, but this is how the tumor is responding. So that option, and with some clinical data we have to support cellular therapy in this setting as well. One more case, like HER2 new positive salivary gland, 72-year male, comorbidities, hypertension, diabetes, allergic to none. Treatment options were surgery followed by radiation done. Then locoregional recurrence, patient was given HER2 directed therapies, especially trastuzumab, progressed in 3 months. TDM1 again progressed in 3.5 months. Capecitabine, laptanib progressed in 4 months. TDXD progressive disease in 2 months. So again, planned for HER2 new CAR T. Harvesting was done 2nd of November, and a patient was lymphodepleted, rested for 2 days, and infusion was done on 3rd of December. And these are the pictures within few weeks. Like this was at onset, and tumor is resolving. There is certain kind of granulation tissue. So that's it for the case presentation. Any comment from the expert panels? Especially in this critical situation where we are not considering the financial toxicity. If patient is fit, finances are not no issue, or we have clinical trials, will you go for?
I have a question for Dr. Isaac. So we do a lot of salvage surgeries in head and neck cancer, and we know from the data from Janek et al. And the data from RMAX study that even after putting that much effort, 80% of the patients do have a disease which comes back within 1.5 years. And even when we give radiation, that is the situation. We try electronomic chemotherapy, in fact it leads to a negative impact on the patient. Do you think in future this would be the patients, before surgery you would want to do some cellular therapy for those patients?
In a recurrent setting.
In a recurrent setting, you would want, who is fit for salvage surgery before doing the salvage surgery?
So when we are looking at recurrent tumors, we have to look at the standard way of choosing a patient. So you are going to choose a patient who has had a better disease-free survival. You want to choose a patient who you can actually resect at R0. You want to choose a patient whom you may be possible to give re-RT. So if those patients are there, you would consider standard therapy. If you have a patient now where the recurrence is in a difficult location You may want to consider second line chemotherapy, to downsize it, and to consider surgery and re-irradiation. In those patients, you might consider this. But you need to have guidelines, because I know that these are very exciting. You would want to do good for your patients, and you know that these are markers for future treatment guidelines which will come in, and we'll have to establish them. So select out a group of patients that actually will actually benefit. So maybe the same, Goodwin in 2000 had a meta-analysis which showed that these are the group of patients that you should focus on. Now you will have to select out a group of patients that nobody wants to treat, like the first case he showed. Nobody has an answer for that. So those group of patients you need to select out and have guidelines. Okay, if it is in these locations, you might use these therapies and have an outcome.
The reason why I asked this question because Rakesh is not here. Rakesh, when you look at the project in submitted to ICMR,
Your mic is not working.
यहाँ पे भी है।
so we have submitted the project for ICMR funding, and that actually deals with such kind of difficult salivary surgery patients who are not a candidate for irradiation, but come back within 1.5 years, and the surgeon feels that it would be difficult to resect, and that's the reason why I wanted to.
See, in the days of the past, we were not radiating again.
Correct.
Today we are re-irradiating. Now I have couple of patients who have received 2 radiations and have had a disease-free survival of few months, and now have come back. I cannot radiate again. No one will. Those are the group of patients that you need to select out.
So, Bhavesh, any comments from your side?
So we do come across, because head and neck patient, if your nutrition is maintained, they are going to live longer, and the recurrence will keep happening within 6 months or 1 year. So this is a very common scenario where we have exhausted 3 to 4 lines of therapy, and then we are in a fix that patient is still walking and coming to you, but the disease is progressing and you don't have a good answer. So I think there we can either put it on a clinical trial or a CAR T therapy, some therapy which is going to have some responses and safety. Both the things we have to take it in the.
I think more needs to be done as far as understanding what is the biology now. Because many times we have the locally controlled disease. Now this patient may have the tongue was controlled, but now he has got a burden all over the body. Now that is something which is different. It may not be actually a tongue cancer now that I'm treating. And that's why you might see benefit with the other therapies which are off-label.
See, in head and neck cancer, and we have worked together. So till recently, we didn't have chemotherapy drugs where, especially in oral cavity cancer, where responses had been higher. We have published our paper of DC. We have published our paper of borderline resectable, and the response rate used to be around 30% odd. It's not larynx, remember, we are not talking larynx. And that's the reason the patient once labeled palliative used to be palliative. We know that once we started using triple metronomic chemotherapy, adding IV to it, and we had a jump in our response rate. Now we have dozens of patients from joint clinic coming as palliative systemic therapy. They have gone back because the responses has been excellent. They have gone back for surgery. So issue was what kind of systemic therapy we had. It happens in other tumors more commonly than here. And here we started seeing when you have this jump, and then we have more resection. Same way, if take palliative immunotherapy has come. Now it has given another hope for people that in case you have patients with in head and neck cancer, median survival used to be 8 months odd. Now if you have those 20-30% patient who lives 4 years or 5 years, and if there is a residual disease, in the past we used to not resect or give local therapy, but in almost most solid tumor we have started looking for, hey, if you have a good therapy, if you're getting something residual, plan for it. For example, lung, we routinely send it. You have a metastatic disease, if you have an oligoresidual and there is an oligoprogression, you send for radiotherapy, because someone has started, one of the part of your therapy has started working very well, and then you require help from other places. In head and neck cancer, since cisplatinum, the fact remains there has been no therapy. I repeat, there has been no therapy till immunotherapy came, which has ever improved survival. No radiotherapy, no technology, nor any surgery, and nor any chemotherapy also. First time you had immunotherapy, and the data for locally advanced came now. So head and neck is in desperate need to have improvement. For me, I'm not looking only for this. In case this result gets sustained and reproduced, and good thing is said the gamma delta, what I understand, मेरी समझ इसमें limited है. This can be not person to person. It can be used, then can be combined. So you're not looking only there. If it works out, looks like this is not so toxic. If it works, reproduce, can it be combined? So for example, T1, T2, you don't want to give it. Prathamesh does it, and you have those 80-90% patients doing very well. But those T4 N3s, those patient recurrent tumor, what you suggested, think about T4 patient recurrence, T3, T4 tumor coming back within 6 months. So Barbara Burtness, she was there, in FHNO recently. What is the trial design? Their trial design is you do for surgery and whatever you do, and one arm only immunotherapy. Resectable patient. I'm saying this was not unresectable patient. That's a trial design going on in United States. What it means, they also feel those bigger tumors when they come back, especially they come back within 9 months or 6 months. If you do surgery, what you were trying to convey was their outcome, survival is around 20% with the best case scenario. So people are looking, can you add some newer therapy? So yes, I do agree that these are some of the things. Once it becomes easier to use, once we have some reproducible data, you will see various combinations. What you're seeing in hematolymphoid. Hematolymphoid, you are not doing CAR T cell, leaving it. You are trying to combine with other therapy, you are trying to combine with immunotherapy, you are trying to combine with bone marrow transplant to see that can you improve outcome. And head and neck cancer, I totally agree. We don't have a real good development for last 30-35 years.
Prathamesh, just one question. So have you found any difference, the previously NSCT as a chemotherapy versus now NSCT as a immunotherapy, operating challenges or anything new, because I always speak about thoracic surgeon, they will say they see a lot of fibrosis and while operating. So do you feel any challenges when, pre-immunotherapy, NSCT?
Not really, I have not seen so many patients where I have had to operate. If they are responding, they go on to have a response. So I'm not really required to salvage it. Another point that struck me was in head and neck cancers, especially oral cancers, we are dealing with not recurrences but second and third and fourth and fifth primaries. These are what you need to look at, because now I do a functional surgery first time. Second time I remove some more tissue. By the time it's the third primary, I don't have any functional human left. I'm removing tongue, I'm removing bone, I'm removing maxilla, skin. I can do one reconstruction, second reconstruction, third time on flap depletion. So these are the multiple primaries that come back, and you will have patients coming with multiple primaries. Same side, but up, down, anterior, posterior. Those are the ones that you require to target. Because now surgery also may not be really functional and patient may not opt for it. So this is where you might look at new modalities.
Just for maybe next year, you will require a whole lot of locally advanced head and neck cancer. Keynote 689, press release is there. That's a new adjuvant immunotherapy trial. Event-free survival is positive. Data is not out. Most likely to be in ASCO. And if it comes out, you will have whole lot of locally advanced head and neck cancer which are surgically resectable, receiving new adjuvant immunotherapy. In near future, most likely, hopefully June, July, you'll have the data in public domain.
Thank you, sir. Thank you for your